by far the most frequent that we do as obstetricians and gynecologists. I'm going to be talking about the evidence, and you will know that evidence on surgery is one of the most difficult aspects, because we have different surgeons with different capacities, different operating skills. We have obviously different cases, and they pose different challenges. And again, in some countries, we have different conditions in operating rooms. So the evidence is limited because of that, but that's what it is. I don't have a lot of time. I'm not going to talk a lot about the preparation, but I will show that there is evidence, and you have to take my word for this, that you should be giving a prophylactic cefazolin about 60 minutes before surgery. There's a lot of evidence on that. There's evidence you should do hair clipping rather than shaving when necessary of the abdomen. There's evidence that you should do disinfection with chlorhexidine alcohol. It's better than iodine, but it takes a little bit longer to dry. So if you need a very quick response, you should use the iodine. For vaginal disinfection, it actually doesn't make any difference whether it's iodine or chlorhexidine. There's quite a lot of level 1A evidence. And you should also avoid adhesive surgical drapes that you have to incise to reach the skin. Not a lot of evidence there, but there's some suggestion to that effect. But I'm going to focus on the technique, the surgical technique itself. And I think for a very long time, for about 70 years, there was only one technique, and it was the Phanesil incision. That was from the late 1900s. There was the Kerr technique, which was the 1920s from Munro Kerr in Scotland. But then in the 1990s, Michael Stark came up with a very different, more simple technique. And he published this in 1995 in the International Journal. It was only described in more detail in another study that was published in 1999 with Michael Stark. And I was interested in this from a very early time, and we published in 2000 modifications to this called the Misgav-Ladash technique, or the Stark technique for cesarean section. Now I'll show you why there's a modification. Basically, it's to do with the incision. Now, starting with the incision, there's quite a lot of evidence from the Misgav-Ladash technique that the Joel-Cohen incision, which is this one you can see here, a little bit higher than the Phanesil incision, has some advantage. But at least in the population in the country where I work, the population are not happy with the Joel-Cohen incision, so we were never able to adopt the Joel-Cohen incision. But what we were able to do is do a Phanesil incision and then dissect upwards, so we would enter the fascia at the level of the Joel-Cohen. And that's the main modification that we published in the year 2000. The evidence it's really very clear that Joel-Cohen has advantages over Phanesil. It comes from the Cochrane review, I think it's 2013. Less febrile morbidity, less analgesia required, less blood loss. There's also less operating time and less time to delivery. And also the hospital stay is reduced. 2 trials, 400 and so women. The Stark technique also involves midline scalpel opening of the subcutaneous tissue and rectus fascia, and then digital lateral expansion of the subcutaneous tissue and fascia opening, rather than doing this with the scissors. There is evidence, and that's relatively recent, that there's no need to separate the rectus fascia from the underlying muscle. You can see it's this trial from 120 women. You can see that skin to delivery time is similar, but there is the difference. So blood loss is increased if you perform dissection, and you increase pain also if you perform dissection. So no real benefit, just lose a little bit of time with it. Digital separation of the rectus muscles is part of the Misgav-Ladash technique. It's also digital opening of the parietal peritoneum. I think we all have come around to doing this rather than doing with the scissors. Digital extension of the peritoneal opening also, and placement of a suprapubic retractor. That's something that we tend to do all over the world. Evidence, again, relatively recent, that there's no need to routinely separate the bladder from the uterus. I think we just lose a little bit of time with that with no advantage. And the evidence comes from these 4 studies, around 600 women. You can see that there's no difference in the rate of bladder injury. but there is an increase in the incision to delivery time. So it's just a little bit of waste of time, apparently. The alternative is to do directly a transverse incision on the lower uterine segment at the level of the uterovesical fold, followed by opening of the fetal membranes with a Cocker or a Kelly forceps. And then a lot of evidence that you should expand the uterine opening digitally with your fingers and not with the scissors. There's this meta-analysis from 2014 showing that if you do it with your fingers, you have less decrease in hemoglobin, you have less unintended uterine extensions, and your operating time is slightly decreased by about 2 minutes. There's also a Cochrane review on this, 4 trials, almost 2,000 women. It's again from 2014. You can see less blood loss, less need for transfusions, and a shorter duration of surgery by about 2 minutes. Now, this is followed by fetal extraction, and nothing to talk about there. Standard prevention of postpartum hemorrhage. I'm not going to talk about that because of lack of time. Standard clamping and cutting of the umbilical cord. Of course, there's evidence that you should do this late clamping rather than early clamping, but I'm not going to talk about that because of time. There's a lot of evidence to suggest that you should remove the placenta by cord traction and uterine massage rather than putting your hand in and extracting the placenta. 13 trials, 4,000 plus women. This is a Cochrane review from 2008. You increase endometritis if you put your hand in to take the placenta. You increase that by about 60%. You increase blood loss. You even increase increase the duration of post-operative hospital stay. So you should definitely not or avoid this unless you really need to get it out very fast for some reason. There's some evidence that you probably do not need to wipe the uterine cavity after placental extraction. This is done in some places with the swab, but there's not really a lot of evidence to show that you should do it. It's not very strong evidence. It's this randomized controlled trial in 2019, 200 or so women. There's no difference in postpartum endometritis. There's no difference in retention of placental products. There's no difference in postpartum hemorrhage. Maybe it's probably unnecessary, although you may argue that we don't have enough data, that the sample size is low. Lots of evidence to say that you should not dilate the cervix in elective cesareans, and again, this is done in some parts of the world. 7 trials, 2,000 women. A Cochrane review of 2018 makes no difference to postpartum hemorrhage. Need for blood transfusion, no difference for secondary postpartum hemorrhage, no difference for febrile mobility or endometritis or uterine subinvolution. So you just spend some time doing this, and it's really not useful in terms of hard outcomes. There's a lot of evidence to say that if you take out the uterus for suturing, this obviously improves surgical exposure, but increases nausea and vomiting under epidural. Very large number of trials. This is a review from 2022, 20 trials, over 20,000 women, and you can see increases nausea and vomiting, intraoperative nausea or vomiting if you have under epidural by 2 folds. And it's about 37% if you take out the uterus. It's only 22% if you leave the uterus in situ for repair, and you increase pain at 6 hours by about 60%. I think nowadays there was some doubt whether you should do 1 layer versus 2 layer. I think the evidence, in my opinion, is sufficient to say that we only need to do 1 layer. Obviously, when you do 1 layer, you need to get the entire thickness of the wall, and sometimes because the uterus opens sort of like this, some people who are not so familiar tend not to include the whole thickness of the wall, and I think that will decrease the size of the thickness of the wall for subsequent pregnancies. But if you look at the evidence, all of it I think is towards 1 layer nowadays. There's still some doubts whether you should use locked or unlocked sutures. It doesn't make really much sense to do locked sutures, but there's not a lot of evidence to say to actually show you this. It's also unclear whether or not you should include the decidua in your suture and which is the best suture material. But I think the 1 layer suture is becoming clear that it is the best. Now, if you look at the Cochrane review of 2014, 9 trials over 13,000 women, There is actually no difference between 1 or 2 layers regarding febrile morbidity, need for blood transfusion, complications of future pregnancies, which is something we worry, particularly uterine dehiscence in the future pregnancies. And you may argue there's only a very few number of cases, 145, but I'll show you some more recent data whether this has increased. No difference in postoperative pain, no difference in maternal readmission. But if you look at the NICE review of 2021, with some new studies, you can see that actually blood transfusion is less if you do the single, and it's less by about 5 times less if you do just a single suture of the uterus. If you look at the other thing that we worry about, which is uterine scar dehiscence in subsequent pregnancies, now we have around 1,670 on in each arm of this meta-analysis, and there is no difference in the incidence of uterine dehiscence whether you do 1 or 2 sutures. This is again a very recent meta-analysis published in Curious. It's a systematic review of meta-analysis. You can see uterine dehiscence and rupture, about 1,000 cases here in each arm. There's no difference. What there is a difference is in operating time. Obviously, it's less operating time if you only do 1 layer suture. It's less, about 2 minutes. And if you look at blood loss, no difference. The rate of dysmenorrhea is slightly increased if you do 2 sutures rather than 1 suture. It's not a big increase, it's about 30%, but it's there. There's some very recent publications from the Dutch network, the 2 closed studies comparing 1 versus 2 single layer versus double layer uterine closure. The first the trial was published in 2021, and there's a 3-year follow-up, and you can see there's about more than 2,000 women. There's no advantage was shown of double layer versus single layer on post-menstrual spotting. No difference in niche formation between 1 and 2 layers, and the subsequent pregnancy rate, live birth rate, was similar, as was the incidence of uterine rupture, and we're talking about 2,000 women. So I think really the data now show you that there's no advantage of doing double layer, so it's preferable to do single layer. Curiously, if you ask which such a material, the only randomized trial that is out there was from 2014, and it compared chromic catgut with polyglactin 1910, Vicryl. And at least we don't have chromic catgut anymore. But curiously, the advantage of chromic catgut was very, very significant in terms of febrile morbidity, need for blood transfusion, etc. So it suggests that monofilament sutures are probably better than multifilament sutures, but the evidence is only partially there. But I think we need to do more trials regarding which are the best suture materials to close the uterus. This is followed by removing the blood, inspecting the ovaries, evaluating hemostasis, and then there is a lot of evidence to say that you should not routinely close the visceral and parietal peritoneum. This is the Cochrane review of 2014. More than 15,000 women. There's no difference in post-operative adhesions. You may argue that there are not many cases, which is true, but there's also no difference in analgesia or infectious morbidity, that there's less operating time by about 5 minutes, less number of post-operative days in hospital, and less chronic pelvic pain. What about rectus muscle reapproximation? Is this beneficial or not? Well, curiously, it's something that we encounter on a daily basis, but the evidence is not very clear here, because if you look at a relatively recent randomized controlled trial, you can see that it increases analgesia requirements if you close the muscle. There's also this study that's from 2019 showing that the visual analog scale of pain is higher if you approximate the uterus. You need more analgesics in the days following cesarean. But the reason why we want to do approximation is because we think it probably decreases rectus muscle diastasis in the long term. Actually, there's no randomized controlled trials that I'm aware of evaluating this. Observational studies have mixed results, so we really don't know whether or not we should do this very simple step. Closing the fascia with a continuous suture is something that we do. We know from general surgery, but not cesarean section trials, that small bites are likely better. We don't really know which suture material. There's not a lot of evidence on this. There's a lot of evidence saying that we should not drain the subcutaneous tissue or subfascial space. This is data from the Cochrane review of 2013. More than 4,000 women, no difference in wound infection, wound complications, febrile morbidity, readmissions to hospital or endometritis. So you should not be draining the subcutaneous tissue. There's evidence that you should close the subcutaneous tissue if more than 2 centimeters in depth, but not if it's less than 2 centimeters in depth. If you look at the whole Cochrane review, there is evidence that you should close the subcutaneous tissue in some women. But if you look at the subgroup analysis, which is from this study in 2004, the only benefit was found when thickness was more than 2 centimeters. If it was less than 2 centimeters, there was no benefit in any wound complications. And actually, the only benefit is if you decrease seroma formation if you have a thickness over 2 centimeters and you close the subcutaneous tissue. What about the last step, which is closing the skin? Well, I think the evidence is both for subcuticular suture using monofilament. There's evidence that you should use monofilament here, or with staples. It's either one or the other. I don't think the evidence for subcuticular suture versus staple is very strong. There is indeed less wound complications and less if you use subcuticular suture, but it's only in regarding wound separation. And many of the trials that used staples, they removed the staples very early. They removed it at 4 days or 5 days. So I think if you do not remove the staples early, the results will probably be the same. There is no difference at all in wound infection. It's just wound separation. And I think that was because it was removed too early. The aesthetical results are exactly the same whether you use staples or subcuticular closure. This is at 6 months. But there is a lot of evidence that you should use monofilament rather than multifilament, because you have less. There's a systematic review from 2024 saying you have less infections of the surgical site, less 30%. So we should be using multifilament sutures or sutures or staples. So with the key messages, I'll leave you with the key messages. Dual cone incision or phanesil moving upwards to open the fascia at the dual cone level. No need to separate the rectus fascia from underlying muscle. No need to routinely create a bladder flap. Uterine opening should be expanded digitally and not with the scissors. You should remove the placenta with cord traction and massage rather than manual extraction. It's probably unnecessary to wipe the uterine cavity after placental extraction. There's no need to dilate the cervix in elective cesareans. Taking the uterus out increases nausea and vomiting. Doesn't mean that you shouldn't do it, but you have to be aware that this may occur if it's under epidural. Single layer suture closure is sufficient. We have to include the entire thickness of the wall. No need to routinely close the visceral and parietal peritoneum. You should close the subcutaneous tissue if it's more than 2 centimeters in depth, and you should close the skin either with subcuticular monofilament sutures or with staples. And with that, thank you very much.
I think lovely talk by Professor Diogo. Even your talk in Dubai was fantastic on cesarean section. And I would like to ask, there were a few questions from the audience. One of them was, in a deeply engaged head, how would you extract it? In our country, we have the Patwadan maneuver, which we use, but what happens in your part of the world? Because there's a high chance of damaging the lower uterine segment and the cervix, because sometimes the incision may be lower down while extracting. In a deeply engaged head, you may mistake the lower segment for the cervix. So how do you prevent it? How do you identify that part?
Thank you very much, Professor Hrishikesh Pai, and thank you for the invitation to be part of this meeting. It's for me, it's always a pleasure to be with you and with the congresses in India. Yeah, I think that's a very, very valid point, because we know that if we have a deeply engaged head, we're usually either in the second stage or very close to the second stage. So we tend, if we do the incision where in the place where we usually do it, it tends to be in the cervix rather than in the lower aspect of the uterus, and that has been associated in future pregnancies with an increase in preterm births, as we know. So we have to go higher than we would normally do when looking at the uterus. So we would still try to find the uterovesical pouch and incise there. The difficulty indeed is getting the head out. Now, I know with people who are less experienced, this is a big problem, and there are several ways that have been described of dealing with this. Pushing from the vagina, the maneuver that you described, and I've personally never experienced such a case, because I think if you go slowly, sometimes it needs to be very slowly down the uterus until you reach the vertex of the head. It may take longer than we expect, but I've always managed to get the baby out in that way. Now, you may say, well, this was 40, 50 years of experience, but I have never encountered such a problem. But indeed, if people do encounter that problem, then the options are the ones that you describe.
Great. One more question was that about the cesarean scar, the niche, which is there. How do you prevent it? Is there any ways to prevent that from happening by doing some methods while suturing and all, so that the cesarean niche doesn't develop, or thinning of the scar?
Well, yeah, thank you. The niche indeed is a problem that we have been dealing with lately, and there have been several attempts to change the technique in order to decrease the incidence of the niche. I think it's now very clear from the data of the Too Close study from the Netherlands that by doing two layers in closing of the uterus, it does not change the incidence of niche. So that's not the issue. It's also difficult to know whether including or not the endometrium in the close, if that actually makes any difference. The data is controversial with the Dutch study, with the Too Close study. They did include it, and but we really can't conclude whether that makes a difference or not. So I think we need more studies to evaluate whether those little differences in the way you close the uterus, whether that makes a difference to the incidence of the niche. So in short, answering to your question, we do not know whether there is anything that we can do at this point in time. We don't know if there's anything we can do to prevent niches.
Okay, and the last question one is there. Suppose you encounter a fibroid, has the thought changed? Because in the olden days, we were taught not to touch the fibroid or the myoma if it is there in the middle of unless it is there in the middle of the cesarean scar position, not to touch it while doing a cesarean. So what is your thought on it? Can we remove the fibroids or myomas while doing the cesarean if they are in the way, or even if they are not in the way?
Well, yeah, there have been several observational studies of describing cases where the fibroids were removed without additional hemorrhage, and that sometimes means injecting adrenaline or epinephrine into the circulation. But these are just observational studies. So my feeling would be that if you don't need to remove the fibroid, then don't do it, then don't touch it. If you need to remove it because otherwise you don't have any tissue to close the uterine scar, then the thing to do is indeed to proceed as one would do in gynecological surgery, try to reduce the amount of blood that reaches the fibroid, and then remove as little as you can so that you have enough space to close the uterine scar.
Okay, so there's one question from me to you, the last one. These were from the audience, but there's been always there's been a chatter in the general public about us doing more cesarean sections and the section rates being higher. So what is your thought? How can we maybe, let's say, optimize the section rate? Maybe in short, if you can tell us what you think about it, how do we optimize rather than trying to say to reduce the cesarean section rate? Is there a possibility of adopting certain important measures which can optimize it? Maybe, I don't know what is the right figure, but that can change in every country. But what is your thought on that?
Well, yeah, thank you. I think that's such an important issue for us obstetricians around the world. And we have been observing an increase in cesarean sections in many parts of the world, not all, but in many parts of the world, particularly in places like Northern Africa, many parts in Asia. There has been an increase. South America, that's always been high cesarean section rates. And in Europe, which is where I work, in the north and the west, we have reasonable cesarean section rates around 18-20%. But in Eastern Europe and in some parts of Southern Europe, it's been increasing. So it's up to about 35-38% in Southern Europe. And in Eastern Europe, it has gone as far as around 45-50% in some countries. So I think it's a big issue because we know that cesarean has increased risks for the mother and also for the baby, particularly if it's performed too early. But the risks for the mother are well defined. They're very clear. So I think we should not be performing cesarean sections without a medical indication. And I think if we do these cesarean sections, it's because of other reasons than for the benefit of patients. And so there should be some control of the cesarean section rates in my opinion, at the country level. In Europe, when I was president of the European Association of Perinatal Medicine, we came out with a statement that was very clear, saying that at the country level, because in individual hospitals you may have increased risk. So the rates that are important are at the country level, at the population level, because that's mixed risk. And we came out with this position statement that at the country level, the cesarean section rates should not be above 20%. Actually, we said it should be between 15% and 20%. And I think that's the evidence coming from many studies, mainly many of them from the WHO, compared the cesarean sections at the country level and maternal mortality and perinatal mortality. So there has never been any study that showed that if you increase beyond 20%, you actually decrease maternal mortality or perinatal mortality. That's the best evidence that we have nowadays. And I think those are the numbers we should be aiming for. And the way to get there is difficult. And I'm happy to touch on that subject, but if we have the time, because it is a very complex issue.
I think this is very important issue for us as well as the FIGO level as well, that we need to see that so there's a lot of learning to be had from the countries like yours, the Western countries, where the rates are quite so. In your part of the world, you have a good 20% rate. At the same time, the mortality rate is very low, as well as the perinatal mortality rates are low. So whatever you're doing there you're doing it correct, isn't it? So we have to emulate it. So certain parts of the world where the section rates are higher, they need to emulate and take the learning what you have already got and bring it to the lower middle income countries where probably the rates are higher. Of course, in certain areas there is because the antenatal care may not be good enough, so that may reflect also on the rate being higher. There is a lot of other issues involved, socioeconomic, but we need to learn from all of you, and that's where we all have to come together and come to a consensus and take your experience and apply it in our areas so that we can optimize our rates, because that's a very important part for us, not only because it also will strengthen our credibility. See, the credibility is also at stake here. People have started viewing us that we are doing it just like that. So we have to see that we are more careful and cautious in advocating cesarean. It has to be done only if it is necessary, I think. And this is a real good learning that we got from you today, and would like to thank you for this wonderful talk and this wonderful interaction, and wish you a good Sunday. Thank you.
Thank you very much. All the best.
Thank you.